The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. Tonight we are going to look at diabetes and peripheral neuropathy and peripheral vascular disease. So we're going to look at diabetes and foot disease. And we know that diabetics are at very high risk of getting amputations and complications as a result of poor foot care and high blood sugars, etc. But before I do that, we are not live. Again, we have not been doing the live programs because of the COVID-19 situation. So it's a taped program that will be replayed for about 2 weeks. But if you have questions, you can ring us on 482-4269, 482-4269, or preferably you can WhatsApp your questions on that number, and I try my best. I can't say I always get around to doing it, but I try my best to respond to the questions. So just to talk first few minutes of the program, Your Health, Your Choice, it's about empowering you to make good decisions about your health, and we often say that your health is in your hands to a certain extent. COVID-19, of course, is still very much on our minds, and our countries where this program is being taped on the first week in June. So we are, I think, now into our phase 3 of relaxing our lockdown situation, and slowly things are getting back to normal. We have been fortunate or blessed in Trinidad in that we have our cases have plateaued out, and we had, I think, one new case last week, which was an imported case. But I just want to give you 2 or 3 updates on COVID-19. I think I mentioned about vitamin D levels a few weeks ago on one of the programs, and I just wanted to clarify. There seems now to be some research surfacing around vitamin D levels. Patients or people with low vitamin D levels seem to have more complications when they are infected with the coronavirus. So we're not saying that low vitamin D levels will make you more at risk of getting the virus, but if you do get the virus and you have low vitamin D levels, there seems to be some evidence that you could have more complications of the COVID-19 infection. Now, of course, we know in the Caribbean we have lots of sun exposure, but one thing that you need to bear in mind that with a darker skin color, the melanin actually protects you against excessive ultraviolet radiation. So it literally is protecting you against skin cancer in its various forms. So if you live in the Caribbean and you are out and going to work, going to your various places, shopping, etc., you should have sufficient vitamin D levels. But one of my gastroenterology friends, colleagues, was saying that he's been measuring vitamin D levels in a lot of his patients, and surprisingly, he's picking up a lot of people with low vitamin D levels. Now, bearing in mind that he's seeing a cohort of patients with things like Crohn's disease, ulcerative colitis, malabsorption syndromes. He's a gastroenterologist. And vitamin D, the main sources of vitamin D in your foods are like fatty fish, tuna, salmon, also things like eggs, dairy milk are high in vitamin D, fortified cereals, high in vitamin D. So those are the foods that you can eat that can raise your vitamin D levels. And basically you need about 600 international units of vitamin D per day to maintain your normal levels of vitamin D. Now the problem is the reason this whole issue of vitamin D came up is that it was noted in the UK, and I think in the US, people with low vitamin D levels were at higher risk of getting complications of COVID-19. Now, one of the things to bear in mind is that people of a darker skin color, so people of Afro-American, Afro-Caribbean extract in the UK in particular, where, if you have a sunny day, especially in summer, it's a big deal. Everybody's doing barbecues, etc. In fact, right now it's fairly sunny in the UK, and I just spoke to my son and daughter, and they were out for a run and out for a walk, so people make good use when the sun comes out. But of course, we know it's limited. So what is being noted is that people of Afro-Caribbean background, because they may not be getting as much sun exposure as if they were in the Caribbean, many of them have low vitamin D levels. And now, at least up to a few weeks ago, the NHS, the National Health Service, was actively encouraging family doctors to begin prescribing vitamin D routinely for their patients. So vitamin D is one of the things we are looking at, and it's an area of active research. The other thing is obesity. People who are overweight seem to have a higher risk of mortality if they contract COVID-19. So we know that obesity is not a nice word. People don't like to use it, but if you're overweight, there's some good evidence emerging. Some conflicting evidence. I was looking at this last night. There's some data from the UK, from the ICU departments, and the UK now has one of the best databases for COVID-19 patients, over 35 or 36,000 people who have been admitted to ICU beds, and they have been able to collate that information, and some of it is conflicting, but it does seem that obesity, hypertension, diabetes, of course, and it seems that if you have type 1 diabetes, you're more at risk of complications than type 2 diabetes, and we're not sure why that might be the case. So type 1 diabetics seem to have more complications with COVID-19. Of course, even if you have type 2 diabetes and you have a serious infection with COVID-19, most of the advice that we've been following is that you are taken off your oral meds, especially if you're on metformin or one of the SGLT2 inhibitors, like Forxiga, Invokana, Jardiance. You're taken off those, and most people abroad especially, if they have a serious infection, they are in hospital, they will be placed on insulin for that period of time. But one of the things I would advise our diabetics is that although it seems that at the present time we have very, very few cases of COVID-19 in the community. Of course, when our borders are reopened, that's going to be the true test of how we handle people who are coming in, and I'll be interested to see what happens over the next few weeks. But what I would advise diabetics is that you really need to make an attempt, apart from all the other benefits of getting your blood sugars well controlled, you need to be conscious of, in this pandemic, that the better sugar control you have, the lower your risk of developing severe complications, even if you had coronavirus. The other area is there's some concern that there's been excessive use of antibiotics in this period of the pandemic, because of course if someone comes in with you with a cough or cold, and I guess if in the UK, the US, other countries, trying to prevent lung infections, it's been noted by the WHO that there's been an increased prescribing of antibiotics, and as a result, increased antibiotic resistance. So there's very little place actually for prescribing antibiotics for COVID-19 because it's a virus, it's not a bacteria. But I guess, when patients come in and they're unwell, the temptation as doctors is to give them something, and sometimes the easiest thing to give is to write out a prescription for antibiotics. So we need to be conscious of widespread antibiotic resistance that can develop. The other aspect of COVID-19 that is emerging is that this is not just a lung disease. We are seeing the whole issue of it's really been more and more prominent that it's been looked upon as a thrombotic disease, in that people are developing thrombosis or clots in the lungs in other areas of the vascular tree. And now what is being thought about is as patients come in, they are placed on anticoagulants to prevent this new evidence of thrombosis. So younger patients with COVID-19 have been noted to have strokes, which is quite uncommon if you don't have diabetes, hypertension, any of those other things. So thrombosis is another area that is becoming more prominent. The other thing that I read just last night is that in Italy there's a doctor who was suggesting that there's a weakening of the virus, but the WHO actually says there's no evidence as yet that there's a weakening of the virus. So if you read that, just be careful. And of course, COVID-19, there's some evidence that there's brain invasion, viral brain invasion, leading to loss of smell. And some individuals with COVID-19, there's psychiatric and neurological symptoms. So I just thought I would update you. Of course, we're still waiting on the further developments of an immunization, and I know there's ongoing debate and ongoing conspiracy theories. With all respect, all due respect, you're free to think and to read and to accept the various things that are being put out there. But for me, I depend on science. I depend on the fact that looking at research, and I think an immunization is extremely important in handling this pandemic. I think when an immunization comes through that is thoroughly tested, we should really be encouraging our patients and the general public to have a big uptake of the immunization. But I already sense that there's going to be some resistance because of the fake medicine that is being circulated. I know some of you may resent me saying that. Okay, so before we go to our first break, I just wanted to dig into our main topic for tonight, diabetic foot disease, peripheral neuropathy, and peripheral vascular disease. I'm going to ask Josh to bring up slide 3, because slide 3 is a good representation. So this is really a synopsis of diabetic foot disease, what we call the high-risk foot. So you see on the right-hand side of the slide, and I'll be explaining what these various terms mean. You have peripheral neuropathy, and then you have peripheral vascular disease. So these are two separate diseases, and the problem is when you have a combination of peripheral neuropathy and peripheral vascular disease, you run into major problems. And I just want to go to slide 4 to show you some statistics. People with diabetes are 25 times more likely to lose a foot than people without diabetes. Now that's a frightening statistic, but that's the reality. More than 1 million people lose a leg every year due to diabetes. That's almost every 30 seconds. And 70% of all leg amputations happen to people with diabetes. And 5 years after lower limb amputation, up to 70% of people may have died. Now, we can just come off that slide, and I want to just explain some of those statistics. So first, the slide I showed, first of all, peripheral neuropathy. So we know neuropathy, diabetic neuropathy, is one of the what we call the microvascular complications of diabetes. So a few weeks ago I explained this, that we have macrovascular complications where the big blood vessels are affected with diabetes, and microvascular complications where the smaller blood vessels are affected, and microvascular complications are diabetic retinopathy, that's diabetes affecting the eyes, diabetic nephropathy, diabetes affecting the kidneys, and diabetic neuropathy. Now, under diabetic neuropathy, the most common form of diabetic neuropathy is diabetic peripheral neuropathy. And diabetic peripheral neuropathy is where the long nerves to the feet are affected. Now, the nerves to the hands can be affected as well, but you'll see some diagrams, some slides in a few minutes with the typical symptoms, but you also can have, under diabetic neuropathy, you can have autonomic neuropathy, which is a form of neuropathy leading to cardiac arrhythmias, abnormal heart rhythms, where you could have gastroparesis, where the food is not digested easily, erectile dysfunction. All those are forms of autonomic neuropathy, which is one form of diabetic neuropathy. And then you can have a very, not very common, but some patients can present with a very painful diabetic neuropathy. This is a separate thing to peripheral neuropathy. And then some patients can just present with an isolated nerve palsy, like a facial nerve palsy or a third nerve palsy, where you have drooping of the eyelids and dilated pupils. So we have various forms of diabetic neuropathy, but the one that we are emphasizing today is the peripheral, diabetic peripheral neuropathy. And peripheral vascular disease talks about clogging up of your arteries. So the double whammy here is that a lot of our diabetic patients have peripheral neuropathy, and we'll show what are the risk factors for that, and they also have peripheral vascular disease. So you have various gradings of high-risk feet in diabetes care, but someone with peripheral vascular disease and diabetic neuropathy are at a much higher risk of losing a limb. And then those statistics are quite worrying. People with diabetes are 25 more times more likely to lose a foot than people without diabetes. And worldwide, more than 1 million people lose a leg every year. And 70% of people who have a leg amputation happen to people with diabetes. So, that's quite worrying, very, very worrying. And the last statement on that slide was 5 years roughly after a lower limb amputation, up to 70% of people have died. Now, why that is? You may say, well, I know people who have had amputations and they have lived for many years. But you see, if you have had a lower limb amputation and it's linked to peripheral neuropathy and peripheral vascular disease, especially if you have peripheral vascular disease, which is clogging up of your arteries to the leg, there's a high risk that you might also have clogging up of arteries to your heart and clogging up of the arteries to the brain. So people who have lost a limb due to peripheral vascular disease will also have a risk of getting heart attacks and also have a risk of getting strokes. So we're going to go to a break in a few minutes, but I just wanted to set that scenario, and when we come back, we're going to talk a little bit about peripheral neuropathy first of all. Just to say, just yesterday I saw a patient who's a heavy smoker having pain in his calves on walking around. His pulses were difficult to palpate, but he was also having pain in his feet. That's a typical patient who has a high-risk feet with diabetes and peripheral vascular disease, because of course we know smoking and diabetes is a terrible combination. We're going to go to our first break, and we will return in a few minutes to Your Health, Your Choice.
Cloud 9 with your new hosts, Renata and Kimberly Singh. Weekdays at 5 p.m. on AZTN The Voice.
The Prime Minister has called for a population to show compassion, humanity, and common sense. Let's fight this together.
We are all facing an unprecedented crisis with the global pandemic COVID-19.
COVID-19 is affecting all of us.
And in this time where the coronavirus COVID-19 is taking the world by storm, I want to encourage you, do not be afraid, do not fear.
We're asking you to wear a mask while you're in public, to wash your hands, and to follow social distancing. We can only stop the spread of COVID-19 by working together.
I want to take this opportunity to encourage all of you to heed all of the advice given by the medical team in practicing social distancing, self-isolation, avoid gatherings, staying at home and stay quarantined.
Please adhere to the calls of the relevant authorities to stay at home.
Trinidad and Tobago, let's flatten the curve. Stay home, stay safe, and save lives.
Let's follow the guidelines from the World Health Organization and our local health officials here in Trinidad and Tobago, and we're going to flatten the curve and get past COVID-19.
Let us stay at home, let us stay safe, and let us stay blessed.
I'm rolling in my two-man army, say my Jesus and I. Stay strong, we're going to get through this together. God bless you.
This was a production of the Ministry of Communications.
Come back to Your Health, Your Choice. Tonight we're talking about diabetic foot disease, we're talking about peripheral vascular disease and diabetic neuropathy. I've set the scene in the first bit of the program. Just to remind you, we're not live tonight. We've not been doing the programs live. These are pre-recorded programs, but you can ring us on 482-4269, 482-4269 for if you have queries, if you want to ask questions. It's better to WhatsApp your questions rather than ring, because that's my main office administrator's number as well. So that's the number where we take calls for appointments. So we had set the scene, giving you some information, some worrying statistics about the risks associated with diabetic foot disease and the combination of peripheral neuropathy and peripheral vascular disease. I'm just going to bring up slide 5 now about prevention. You know, what do we do to try and prevent amputation? So between 49 to 85% of amputations can be prevented through a care strategy that combines now prevention, multidisciplinary treatment of ulcers, appropriate organization, close monitoring, and education of people with diabetes and health professionals. So I'm just going to come off that slide. So our goal really should be how do we prevent these high rates of amputations, because in Trinidad and Barbados as well, and maybe the other Caribbean islands, we have relatively high rates of amputations per capita of the population. So when you compare our rates of amputations in terms of our population, it's very high. Now there could be various reasons for that, and you know, one of the questions we can ask is how and when do people have their feet examined in our country? Now that's a good question. How? In fact, let's just bring up slide 6, because I want you to just look at those two questions on slide 6. So if you're diabetic, the question you need to ask yourself is how and when do you have your feet examined, and what conditions put people at high risk of injury in our country? So there are two important questions there. So we can just come off that slide, and I just want to address that issue. Now, I worked with the Southwest Regional Health Authority for a number of years, and the goals that we had set out is to set up this multidisciplinary diabetic teams in the community, where we were able to move a lot of the diabetes specialist care out of the hospital setting into the community. And it's very much a UK-based strategy that we were trying to recreate. Now, we had a certain level of success in developing specialist clinics and training nurses to become diabetic specialist nurses, or certified diabetes educators, as they're called in the US. But one of our challenges, and one that we have not been able to solve, is having proper podiatry available on the government service. As far as I'm aware, we still do not have any state-registered or any fully trained podiatrists in the government service. Now, it's not the government's fault. I sat on panels trying to interview people, but there are not many fully trained podiatrists. Now, when I talk about a podiatrist, I'm not talking about people doing pedicures. They do a good job, but I'm talking about people with diabetes going to someone with a specialist training in looking after the feet. These are not doctors. These are podiatrists, which is a 4-year, or I think it's a 4-year training course that is done. Now, in the UK, what would happen is that when you came into the diabetic center on the particular day, you would see the diabetic physician, you would see a certified diabetes educator or diabetic specialist nurse, you might have your retinal photography done, and then you may see a podiatrist if necessary. Not everyone would need to see a podiatrist, but the doctor would kind of stratify people with high-risk feet, and then they would be able to see the podiatrist on the same day or on a following day. So it was a multidisciplinary approach, and I think that's where we are falling down still. So, what I would say to the Ministry of Health, again, while it's good giving out scholarships to people to do medicine and engineering and law, I think the Minister of Health and his team, they need to think about creating scholarships for people in podiatry care, because if you can save a foot, you are saving a life in terms of what we know the complications can be, the socio-economic burden to that household as well as to the economy is vast after an amputation. And very often people begin with a below ankle amputation, and then it goes to below knee, and very often it ends up with above knee amputation, and that person is then disabled for the rest of their life. You can get prosthetic limbs. They are available, and I know sometimes through the government service there's the social care packages that can be rolled out, but prevention is the strategy. Prevention and preventative care is not very can I use the term sexy medicine? The tertiary care medicine, where we set up the big centers with MRI scanners and CT scans, and we build the big institutions. That's good for photographs, etc. But when we talk about preventative care, that's the key to good diabetes management. You see, by the time patients come into us with already established complications of diabetes, we are fighting an uphill battle. So the question is, how and when do people have their feet examined in our country? Well, that's a good question, because many people are going to our chronic disease clinics and they are never asked to take off their socks and shoes or take off their sandals to have their feet examined. So one of the things I want to say to you as a diabetic, you need to ask your physicians or your nurses, etc., about foot care, and your feet needs. So the doctor may not have time to do it, but I know some of our nurses have been trained to a certain level to examine feet and to highlight those who are at high risk. So that's a strategy that the Ministry of Health can think about, training our nurses to do foot care of basic feet examinations to highlight the possible complications. And what conditions put people at high risk? Well, of course, we know poor diabetic control. We know that smoking could put your foot at risk. But of course, we are living in the tropics. So people go to the beach and they walk around barefooted. So one of the basic pieces of advice that we would give to diabetics is that you need to have proper footwear. You need to protect your feet, and even if you go to the beach or you go on a lime, as we say, a river lime, you should have proper footwear. Even if you're going into the water, there's footwear you can have to protect your feet, because especially if you go into the rivers, you may step on a sharp stone. And I'll tell you, a diabetic foot ulcer doesn't develop overnight. Sometimes it's a simple blister, which then becomes infected. And because of neuropathy, which you have associated numbness, you don't recognize that there's an infection setting in. And I often say that pain is a God-given gift. Why do I say that? because pain is a warning signal. You know, if you have numbness of the hands and you put your hand in a fire or on a hot pan and you don't feel it, you will get burnt. Same thing with your feet. Normally, if you have an infection, you will feel that it will be painful. But if you have diabetic peripheral neuropathy, you have numbness in the feet, the infection sets in, and you have a rip-roaring infection before you get to the doctor. So protecting your feet is often very important. So we're not going to be able to complete all the slides today, but I'm going to just focus in on peripheral neuropathy and bring up slide 7, peripheral neuropathy. And this is often called a sensory motor neuropathy. It's the most common form of neuropathy. Remember I said that diabetic neuropathy can present in different forms. You have autonomic neuropathy, you have diabetic motor neuropathy, but peripheral neuropathy is the most common form. It affects approximately 50% of diabetics after 15 years, and it affects the long nerves of the feet and legs, and it often starts in what we call a glove and stocking distribution. So the hands and the feet, very importantly, it's most times bilateral. Both feet are affected, both legs are affected, and equal symptoms in both limbs. So I'll just come off that slide and make a point on this. This is where taking a careful history is important, because not all foot pain is diabetic neuropathy. So if someone comes into me with pain in the leg, pain in the feet on one side, immediately, if I take a careful history from the patient, I'm thinking, well, is this diabetic neuropathy, or is this more nerve entrapment, sciatica, or is it some other condition? And especially if the patient is complaining of calf pain when they're walking around, that might be more claudication pain, or what we call circulation problems. So diabetic neuropathy is most often bilateral, affects both legs, and the symptoms, sometimes one foot might be more, the symptoms might be more than the other, but generally it affects both equally. So what are the risk factors? And this is a very important slide 8. What are the risk factors for peripheral neuropathy? So slide 8, poor blood sugar control. That's on the top of the list. The longer you have diabetes, the more at risk you are at having diabetic neuropathy. Age, as you get older, of course you may have diabetes for a longer time. Height, now that's a little bit of a strange one, but the taller you are, the thinking is you might be more at risk of neuropathy. And one that we often ignore, excessive alcohol intake. So I'll just come off that slide for a minute. That last one might be surprising because you may not associate excessive alcohol intake with diabetic neuropathy. Just bear in mind, though, that excessive alcohol intake can present with other types of neuropathy. There's an alcohol-related neuropathy where you have thiamine deficiency, and you can have a neuropathy associated with alcohol, excessive alcohol intake. But the main one that I wanted to emphasize there is, of course, poor blood sugar control, and you know, we go on and on about trying to get our diabetics to understand that blood sugar control is, you know, a long-term job. And sometimes, you know, diabetics coming to me and they're just kind of fed up with having to do their blood sugar readings every day. They're having to take medication. You know, people often say to me, Doc, I'm fed up taking all this medication, especially when people are on insulin. I'm getting tired of having to stick myself every day. And, you know, I try to be optimistic and try to pass on to my patients a positive framework for thinking about their health. And, you know, I often say to people, yes, I know diabetes is not an easy condition to live with, but it's a condition we know how to treat. So, I want to emphasize that we know how to treat diabetes. In fact, over the last 10 to 15 years, more so the last 10 years, there's been an explosion of new drugs and new insulins and new interventions in treating diabetes. There have been new ways of monitoring. So I tell people now a lot about continuous glucose monitoring, CGMs. We have one type of CGM, the Medtronic iPro 2, I believe, in Trinidad. But a lot of people see the Freestyle Libre patches advertised, and I have a few patients who have brought in the Freestyle Libre patch. It's a patch you put on, it's a self, patients can do it themselves. You can't get it from America without a prescription, but you can get it from Canada or the UK, I think, without prescriptions. But then the readings are going to be in millimoles, but you just multiply by 18. So it's basically a patch, and you can, and it comes with a monitor. You just pass the monitor over the patch. Well, now I've been hearing that you can use your iPhone, and you get a reading at any time of the day. There are also the professional patches that can be done where you download the information and you can get very nice graphs looking at glycemic control. So one of the things I just want to say about diabetic neuropathy and glycemic control is that you need to persevere. If one particular medication is not working, there are lots of other options. So, type 2 diabetes especially, it's quite a complex illness. We talk about the ominous octet, where you have about 8 pathophysiological mechanisms going on in type 2 diabetes. And unfortunately, on the government service, we are limited still to metformin and either glycoside, or I think Deonil has been removed. So basically you have just 2 out of hundreds of oral, well, at least about 8 or 9 different groups of oral hypoglycemics available. And then, of course, you have insulin, but of course, because of the cost of some of the more modern insulins, we're still limited to 70/30 insulin. NNR, Lantus used to be available in the government service, but was taken off. And there are even newer forms of insulins. And of course, we have insulin pens in the private sector, which, I find, very often patients come in and they're very hesitant to go onto insulin. And when I get the pen and I show them how to do that first injection, they're often surprised how relatively easy. And then I get the WhatsApp messages, because I give patients my telephone number, and very few people abuse my number. They would send me their blood sugar levels by WhatsApp, and after struggling with the limited tablets on CDAP for years, we introduce insulin, and they begin to see much better glycemic control. So glycemic control is extremely important, getting your blood sugar under control. And I don't want to go back over the figures, but get familiar with your pre-meal readings, 2-hour after meal readings. Pre-meal, you want to be between 90 to about 120 to 130. 2 hours after eating, roughly less than 180, some the American Diabetic Association says, but I prefer the figure of below 160 2 hours after eating. And of course, in pregnancy, you're looking for even tighter control. And then be familiar with the blood test called the HbA1c. At least twice a year, if you're diabetic, you should have your HbA1c done. And that's the blood test that gives you a 3-month average of your blood sugar. So just doing a spot finger prick test is not enough. You need to be doing your HbA1c at least twice a year, because that will give you a 3-month average. I think we may have just a few more minutes before our next break. I just want to bring up slide 9, which are the common symptoms of nerve damage. And boy, I see this so often. Symptoms of burning, pins and needles, pain, and sometimes there are no symptoms at all. So just for a second, I know many of you looking at the program will be able to identify with this, the burning, pins and needles, and pain, the symptoms of peripheral neuropathy. Now, I have to tell you, I see so many patients with symptoms of peripheral neuropathy. Some of them have seen the program, have heard us talking about it, and I'm going to come back to some of the drugs that we can use and some of the interventions we can use. But you know, very often patients come in and they say that they have had these symptoms for months or years, and it affects their sleep, it affects their daily life. And you know, the range of from 1 to 10, the scale that I see patients coming in with. Some patients, they don't volunteer the information. I ask, one of my routine questions, especially for my new patients, is do you have burning in the feet? Do you have numbness in the feet? And some patients will say, oh yes, I do, but it's not that bad. And then some patients come in, and they come in particular for the severe burning in the feet. So we're going to go to our second break now, and we'll come back for our final segment of Your Health, Your Choice.
The Prime Minister has called for population to show compassion, humanity and common sense. Let's fight this together.
This is Nikki Crosby, and COVID-19 is no joke.
The best thing you could do to bless the nation right now, Olia, is stay home.
There's one enemy, which is the coronavirus.
I know that it's real difficult to be inside all the time, but find different things to do.
Stay away from crowds, obey the law, basically, you know, just stay safe.
I urge that you take care of yourselves and your loved ones.
Wash your hands frequently, and of course, be wise and sanitize.
Stay safe, stay indoors.
Stay inside, practice social distancing.
Stay home, stay safe, stop the spread of coronavirus.
The battle right now for us to stop COVID-19 is for you to stay home and keep distance.
I'm doing my part to flatten the curve, all right? We need you to do your part.
Stay home, stay home, stay home.
This was a production of the Ministry of Communications.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
Welcome back to Your Health, Your Choice. Just to remind you, we are not live. Over the last few months, we're doing pre-recorded programs. So if you have any questions, you can WhatsApp your questions, better than ringing on 482-4269, 482-4269. That's also the number for more information about the Anaposis Medical Center and the church, the Anaposis Chapel. So we've been talking about peripheral vascular disease, and I've showed you the symptoms, burning, pain, numbness, and people come in, and some people can get, you know, quite depressed, because can you imagine having this burning pain in your feet, unable to sleep at nights? And what I find sometimes is that patients have been have talked about this, have maybe told their healthcare professionals about it, and sometimes there's a little bit of a fatalistic approach to this, but there are several therapeutic interventions that can be used. I know a lot of people give vitamin B12. You know, there's some evidence that that can help. There's a natural supplement called alpha-lipoic acid. It's an antioxidant. But really, the prescription drugs that can be used, and I know some people may say, well, we're already on tablets or insulin medication, 2 or 3 tablets for diabetes. Many diabetics have hypertension, and they're on 1 or 2 different tablets for hypertension. They are on cholesterol tablets, they're on aspirin, and here we are seeing another medication. Well, the physiotherapy may help. there are some physiotherapists who have special devices that they can use to help with the nerve end pain. Some people claim that massaging the feet can help, but the top line drug for diabetic neuropathy is Lyrica. I know if you see Lyrica advertised on cable, you'll see loads of side effects, but a lot of my patients are on Lyrica and they do fairly well. We start on a low dose and we titrate up. There's Cymbalta or duloxetine. It's marketed both as an antidepressant, but it's used widely for diabetic neuropathy. And there is gabapentin, and there's apogabapentin, which is not as expensive as Lyrica and some of the other drugs. On CDAP, there's lots of people use amitriptyline. It does can help. It's a cheap drug, but some people have side effects with amitriptyline, excessive drowsiness, etc. So there are therapeutic options, but remember, we must kind of go back a bit and say that the fundamental aspects still apply. Good blood sugar control, good blood pressure control, good lipid control, staying healthy, a little bit of exercise, eating healthily, all those things go in. You see, I often tell a patient, I'm not just treating a foot, I'm treating a patient, I'm treating you holistically. So if I just talk about your feet, if you come in and you just want to focus on that and medication for that, and we miss the fact that your diabetes is not well controlled, or you have hypertension, or you're drinking excessive alcohol, then we're missing a holistic approach to diabetic neuropathy. Now I'm going to show you some some slides that may be a little bit shocking, but bear with me. Slide 11. Slide 11 shows maybe a little bit of a horrific picture, a big nail going through the foot, and you might be surprised that that patient didn't have much pain. So that's the numbness associated with it. And then slide 12, you see, if you look at the left part of the slide, you'll notice that that patient has already lost 2 toes. So they've already had 2 amputations. And if you look carefully at the just under the toes, you can see some hard skin buildup, callus buildup. So that's sensory nerve damage. We go to slide 13. Slide 13, and we see wasting. This is motor nerve damage. If you notice between the toes, there's wasting of the muscles, and on the right hand side, you notice a second toe. That's called a hammer toe. The toe is bent, and that's as a result of motor damage. And then slide 14, you see a little bit more clearly. So a typical neuropathic ulcer, and if you look at the right-hand side of the slide, you see an ulcer developing. So first there was callus buildup. So just under the big toe, the metatarsal heads, that's an area of maximum pressure, and that's where typical diabetic foot ulcer develops. And that's why if there's callus buildup, that needs to be dealt with, because that can break down and develop into a foot ulcer. Slide 15. Now this is what we call autonomic nerve damage. What do I mean by that? You notice the foot is very dry. So what diabetics lose is the sweating mechanism in the feet, and the feet can become very dry. Other areas of the body can become dry, and that's why we advise not just women but men to cream their feet who are diabetic, because it's necessary to keep the skin soft. So you see on the heels beginning to crack, and then that can break down and cause problems. So we can just come off that slide and just recap what I've said so far. So you see those diagrams, which is it's a little bit shocking, some of the foot problems we see, but if we can pick up those at an early stage, then we can prevent the later stages of amputations. As you saw, one of the diagrams I showed, the person had already lost 2 toes. And it's like other medical problems. Once you've had one heart attack, you are at a higher risk of getting subsequent heart attacks. That's a basic principle in doing medicine. We call what we call risk factor stratification. So all patients are not equal. If a 21-year-old patient comes in with a cholesterol of 210 and the rest of the lipid profile is okay, I probably wouldn't be putting them, in fact, I wouldn't be putting them on a statin. But if a 55-year-old man comes in having had a heart attack and the cholesterol is even 190, and the HDL is not too bad, the indications are that patient should be on a statin, should be on aspirin to prevent recurrent heart attacks. It's the same thing with strokes. Once you have had one stroke, you're at a higher risk of having subsequent strokes. So we need to reduce all the risk factors for subsequent vascular events. And it's a similar thing with diabetic neuropathy. So there are various ways of examining the feet, but one of the things is you need to take the shoes off. So, you know, when you, all my patients, when they come in for the first time visits, etc., especially, I ask them to take off their shoes and socks so we can just at least examine the feet. Even in COVID-19, I'm still examining my patients. I know in the UK, a lot of consultations are being done by telephone triage or by video consultations. We have not got to that point yet here in Trinidad, and I know in a lot of the hospital clinics right now, prescriptions are being rewritten. I'm not saying that's wrong or right, but I'm saying that in my context, I am still seeing patients. Yes, I'm doing the necessary hand sanitization, wearing the masks, etc. But if a patient needs to be examined, a patient needs to be examined. And I'll just show you slide 17. It's what we call a tuning fork. The one on the top, I'm not sure if we have in Trinidad. So what we use is this little sensation. It's a device where we just touch lightly at the bottom of the feet, and we ask the patient to close their eyes and tell us what the sensation is like. So that's testing sensation. You can also test vibration, thresholds, and test the ankle reflexes. So just come off that slide. So when we look at examining the feet, just touching the feet, feeling the temperature of the feet, feeling the pulses, the dorsalis pedis, posterior tibial pulses, just looking at the feet, whether the skin is very dry, just looking at a foot. Within 10 to 15 seconds, you can tell whether that patient has a high-risk foot or not. And then doing the test for sensation, you can do ankle reflexes, but using a tuning fork to test vibration thresholds are very important. So just slide 18. Quickly, we can look at this assessment of high-risk characteristics. So we showed these slides already, but if you look at from the right-hand side, left-hand side, sorry, you see the hard skin building up, the callus build up, then you see the dry skin, then you see the wasting of the muscles. And if you look at the last slide on the right hand side, on the bottom bit of the slide, you see between the toes, a lot of diabetics can get fungal infections, and although that is not putting the foot at high risk of amputations, the fungus should still be treated, and it is probably an indication that the diabetes is not well controlled, right? So we can come off that slide. So I've tried to give you an overview there of the risk factors for neuropathy, diabetic neuropathy, trying to pick up feet problems at an early stage, so we prevent. So the two areas, let me just say, the two typical, so when a patient comes in with a foot ulcer, it can be 3 types of ulcers. You can have venous ulcers. So a lot of diabetic patients come in and they hear about diabetic ulcers and they're worried, and when they come in, it turns out it's a venous ulcer. It's not a diabetic neuropathic ulcer. The venous ulcers are more on the side of the ankles, just above the ankle, most times just on the inside or the medial side. And those ulcers are not, let me put it this way, not as serious as the neuropathic or the peripheral vascular disease ulcers, but they can be very difficult to treat, and they take a long time to heal, because for something to heal properly, I always tell patients, it's a combination of good blood supply, good blood sugar control, and repeated proper dressings, etc. So venous ulcers is generally on the inside, just above the ankle. Then you have the arterial ulcers, which are more at the end of the toes, the tips of the toes. And the typical diabetic neuropathic ulcer is under, very often, the big toe area, the metatarsal head, just under the big toe area, or under the heel. That's the other area where you have big problems, big pressure problems. Right, well, I'm going to have to probably continue this. Time has gone. I've talked so much for the last 50 minutes or so. So we only have about 3 more minutes. When we do the next program, I'm going to come back and show you something called Charcot's arthropathy. Charcot's arthropathy. Charcot's is a condition where a lot of people mistake it for an infection of the feet because it's warm, it's swollen, but it's typically a the foot is all deformed, it's swollen, the pressure areas, the whole biomechanical aspect of the foot is disrupted, the bones have collapsed, and these patients have a high risk of foot ulcerations, but it's the approach to this is proper foot care, proper footwear. So very often we can refer these patients to people who can do a special cast and build a shoe for diabetics with Charcot's arthropathy. Well, I've tried to cover diabetic neuropathy. I was intending to cover peripheral vascular disease as well, but I can't do that today. I'll do that probably in the next program. Remind you, 4824269. 4824269 is the number to call for more information, appointments, and for information about our church as well. So I put on my pastoral hat. Of course, we've been teaching and meeting online, and I want to thank all of you who have been joining us online on the Trinidad and Tobago Anaposis Center's Facebook page. Many of you have been interacting with our services on Sunday mornings, and I encourage you to go back on the Facebook page and have a look at last Sunday's service, where I was preaching about divine direction. I've been talking about that for the last few weeks, and I want to remind you the tagline for the series: the decisions we make today will determine the stories we tell tomorrow. The decisions we make today will determine the stories we tell tomorrow. So you have crucial decisions to make in this season of your life. Do not blame anyone else. Make wise decisions. And how do you hear from God? Well, 2 of the points I made on Sunday morning was the Spirit's prompting, being able to sense when you feel a gentle nudge of the Spirit. And you can only sense that if you are spending time with God. And then the second point I made was walking in certain uncertainty. Well, that's a big one that I don't have time to go into. But some of you are looking for a 10-year plan from God. No, God just wants you to get out of the boat, begin to walk on water. You might be uncertain, but as you take a step into uncertainty, your faith is built, and you begin to see the big plan of God for your life. Thank you very much for joining us on Your Health, Your Choice. We'll come back with another program, but this program is played on Wednesday nights and Thursdays around 1 p.m., I believe, and we will return with Your Health, Your Choice in 2 weeks' time. Thank you very much.